Hello students, welcome all. Today we are going to discuss a very brief, concise and important topic of Xerostomia and Sialorrhea. You may come across these patients in your clinics as well as in exams. A short note may be there. So what happens? Saliva is very important body fluid. It is present in the oral cavity. It has a potential to cause infections as well as protection of the oral mucosa. So, xerostomia was defined by Dr. Hutchinson in 1898 as a symptom and not a disease, so which may be influenced caused by many factors. So, not all the people who complain of xerostomia are actually having salivary gland diseases. There can be some local dysfunction or some systemic disease which may be manifested as xerostomia. Common signs and symptoms include oral dryness. Naturally, when the salivary secretions are less, the main function of the saliva is lubrication and that is lost, resulting in dryness. Halitosis, because the oral microbial content is altered. Burning sensation, because the lubrication is not there, there are chances that the food you are having this while doing your daily movements, there will be abrasion of the mucosa. So burning sensation, loss of sense of taste because saliva, the component of the food has to be dissolved in first saliva and then to be sensed by the taste organs, your taste buds of the tongue. Difficulty in swallowing, again because the bolus formation is there. So the tongue tends to stick to the palate, making a patient uncomfortable and decrease the retention of the dentures. If we look at the signs and symptoms, so you can see that here how the mucosa is looking like. It seems glossy and dry, and the tongue is giving the appearance of glossitis. So fissures are there and see. So there will be salivary pool disappears. Saliva pools in the oral cavity, you must have noticed when you examine the patient that when you ask the patient to keep the mouth open for like few seconds, there is collection of pool of saliva in the mandibular posterior region. This results in accumulate difficulty in your cavity cutting in the mandibular molars because isolation is difficult and all. That pool is absent if the patient is having dry mouth. So if that pool is present, you can say that it is a not the very severe condition and your mouth mirror will tend to stick to the mucosa. Moreover, the duct orifice, viscous or opaque saliva may be visible. Then coming to the tongue will have glossitis, fissured, red papilla atrophy, angular cheilitis at the corners of the mouth. There will be red inflamed area. Rampant caries, most common and most deleterious side effect of the xerostomia. When amount of saliva and the composition is altered, it results in increased progression of the caries rate, resulting in rampant caries. So the cusp tips and the cervical areas, they are rapidly involved, they cause and cause problem to the patient. Periodontitis also is increased again because of uh, altered in the oral flora and the patient having not maintaining the oral hygiene properly. Candidiasis, opportunistic infection. Again, if there is alteration in the bacterial flora, so the opportunistic infection like candidiasis tend to develop quickly. Yeah. Then next is etiology. The most common cause of xerostomia is aging. Dry mouth is more common in older people and that too in female subjects because of increase in the fat content of the salivary gland. Whenever the acinar or the glandular content is reduced, it results in xerostomia. Then certain foods like alcohol, beverages and smoking, they affect the uh, saliva production. Drugs like antidepressants, especially lithium based drugs, antisecretories, antihistaminics, and anticholinergic, antihypertensive, anti-inflammatory drugs, all these affect the salivary gland secretions. Systemic factors like emotions, nervousness, or excitation affect the salivary flow rate. Encephalitis, dehydration, anemia, nutritional deficiency, all these cause decrease in the saliva. Radiotherapy, I have already told you that radiotherapy, it can cause acinic atrophy, serous acini, you are aware of this, and the saliva gets thickened, altered electrolytes, pH is reduced, secretion of hemoglobin is less. All these things with rampant caries manifest in the effect of radiotherapy, resulting in xerostomia. So if it is more than 1000 rats, it causes dryness. If it is more than that, it causes irreversible changes. Then coming on to Jagran syndrome. It is an autoimmune disorder with exocrine invasion, mainly affecting the females. Affected patients are mostly female, around 80 to 90%, and that too in the middle age. So, why it is called Jagran syndrome? Because it was discovered by an ophthalmologist named Jagran. He noticed that there was dryness of eyes, and then concomitantly he noticed these patients are having dry mouth also. So we have primary and secondary form. In primary, there is keratoconjunctivitis sicca, that dryness of eyes resulting in keratoconjunctivitis and xerostomia. Then secondary form of this syndrome, there will be associated other connective tissue disorders like rheumatoid arthritis, your scleroderma, SLE, that is systemic lupus erythematosus, and polymyositis. Other salivary gland diseases like obstruction or infection of the gland resulting in decreased flow of the saliva. Sarcoidosis or amyloidosis, where the glandular content is replaced by the other components. Benign or malignant tumor causing compression on the gland. Excision of the gland or congenitally missing gland. All these can also result in xerostomia. Now, how do we diagnose? First important thing is history taking. When we ask the patient the chief complaint, one of the things the patient may mention may be the dry mouth, or he may be having problem with the dentures, or there may be burning sensation. So we have to check out. Sometimes the patient is aware, sometimes he is not that much confident about whether it is xerostomia or other problems. Then we have to look for the symptoms that we recently discussed and do the clinical examination to look for the signs. Certain important salivary special investigations when we are suspecting xerostomia is our salivary flow rate. First, we have to check that whether it is true or pseudo condition. Okay, like whether the salivary glands are functioning normal or there is some deficiency in that. Or then we have to check the composition of the gland by doing the biopsy. Salivary flow rate or sialometry. It is the thing that we check what is the flow rate of the saliva. Stenson's duct is the opening of parotid duct, and what we do at the resting, we allow the resting flow rate is we check it for 10 minutes, and for stimulated flow with the citric acid given to the patient. There are two methods. One is resting, other is stimulated. In stimulated, we don't ask the patient to do anything. In stimulated, we ask the patient to use citric acid. We give him a lemon juice or something, or we can ask him to chew on the chewing gum, so that the salivary flow is stimulated. If it is less than 0.1 ml per minute, it is xerostomia. If the stimulated flow rate is less than 0.5 ml, is irresponsive xerostomia. So what are the normal rates? Normal rates for stimulated flow of saliva is 1 to 2 ml per minute, and that for the normal, here I am adding the normal is 1 to 2 ml per minute, and unstimulated or the resting flow rate is normal is 0.3 to 0.4 ml per minute. Okay. Then talking a bit about salivary skin scanning. This you will read more in the final year with the special radiographic techniques. But you should know that there is something called salivary skin scanning, which is technetium 99. This is an a special element which is given and its emptying rate is recorded. Okay. The uptake of the technetium 99 by salivary gland function as inner tissue is present, and high sensitivity and non-invasive procedure. So what has to be done in specialized conditions? Then silochemical analysis. We analyze the various ions, sodium, potassium, aminoglobulin, amylase, okay, and look for the specific gravity or the specificity, the density of the saliva also. That will tell us whether it is mucinous or not. Then the Jagran syndrome, in Jagran syndrome we can find the antibodies, so it has a diagnostic value. Laboratory values include your elevated ESR, IgG, rheumatic factors, all these things. Okay. Then silography. Silography, it is the installation of radio-opaque fluid into the glands, identification of non-calcified cyaloliths and tumor, and also used for, but it is unsuitable for the diagnosis of xerostomia. It will help you to locate whether there is any, some non-calcified cyalolith. Have it been calcified, you can view it in the radiograph. You can take a occlusal radiograph with variation in your KVP, and you can find the calcified cyalolith, but sometimes they are non-calcified, so we can take that. Management. So if we look at the management concisely, it is about the dietary and the environmental condition. We have to do preventive dental care and give the patient salivary stimulants and substitutes to make him more comfortable. Among the dietary, we have to ask the patient to avoid the drugs that may produce xerostomia, like avoid dry and bulky fluid, take high fluid content, avoid alcohol, smoking and sugar, and take protein and vitamin supplements. So environment include your maintaining the optimal air humidity, using Vaseline to protect the lips, that will prevent angular cheilitis, and smooth chart the cusp if any due to attrition or any other reason, because they will tend to cause trauma to the mucosa more. Then oral hygiene instruction should be clear. Such patients should be avoided giving alcohol based mouthwashes because they cause more dryness. Then topical fluoride with the carrier use can be used. Like topical fluorides become very important because the patient may be having rampant caries. Fluoride rinses and chlorhexidine rinses, but try to use with water base or aqueous base, you can know. Antifungal medications may be required by some patients for like miconazole or nystatin or cotrimoxazole if they are denture bearing and they have burning sensation and you find atrophic candidiasis there. Salivary stimulants. Salivary stimulants like your chewing gums, they will stimulate the flow of saliva. Okay. Then diabetic sweets, like that means your non-cardiogenic sugars which can be chewed upon. Silogogues, which increase the secretions like pilocarpine, but they come with their own side effect. Salivary substitute, that means they have a composition similar to the saliva. Not all the antibodies, but at least the physical property of the saliva can be met, like carboxymethyl cellulose or mucin. Then if it is with fluoride, it is called saliva orthana, and mixture of glycerin and citric acid, and your natural oral antimicrobial contents. Then Sialorrhea, a few words regarding Sialorrhea. It is a condition where there is excessive salivation or water breath, it is known by the patient. Etiology can be any irritating factor in the oral cavity. The patient may complain of that there is over secretion of the saliva and he is not able to make him, it is not controlled. It is always coming out of the mouth. So it can be some kind of irritation like your aphthous ulcer. In newly fitting dentures or restoration or prosthesis, sometimes they increase the stimulation. So more of the secretions. Then heavy metal poisoning, lithium. Lithium, you must know that patient may be not telling you directly that he is taking lithium, but you should know that lithium is given for deep endogenous depressions, bipolar disorders, some severe psychological conditions, you can say. Then rabies, newly fitted dentures, I told you. Then GERD, that is your gastroesophageal reflux disease. Patient has a history of acidity. He feels some secretions coming into the mouth. Mental retardation and cerebral palsy patients, they actually don't have not much of the oral secretions, but they have difficulty in swallowing. So the regular swallowing of the thing is saliva is like not that good, resulting in water brash. Idiopathic paroxysmal sialorrhea. So it is idiopathic, we don't know, but it is there at a certain point of time. Then common signs and symptom of sialorrhea: drooling, choking, and macerated sores sometimes constant soiling of the clothes. It becomes difficult for the patient to carry out confidently the social life. Sometimes it resulted in epigastric pain prodromal to that. Management include transient or mild or no treatment is needed. If there is any irritating factors like you can say some kind of sharp edges, pericornitis, gingivitis, periodontitis, then we have to treat that. Otherwise, if the patient has systemic condition, we have to refer it to the medical management. Anticholinergic medication like atropine and scopolamine can be given to these patients. If the problem is excessively over, then we can do relocation of the gland ducts. That is, we place them more towards the posterior so that the saliva is drained out into the in the posterior region and is swallowed easily. So we can conclude that whether it is xerostomia or sialorrhea, they exist in the oral cavity should be treated with the proper management, and every dentist should be aware how to manage this condition, what are the etiologies and what investigations we can do. So this is a brief about this topic. So students, I want to do the following assignments, but at the same time you have to read in detail from your textbooks, and uh, then we will discuss how to elaborate in. If you have any doubts, let me know so that we can discuss it. Okay, so this is your assignment question. Discuss the composition of the saliva, its functions and normal secretory rates. Write short note on investigation used for salivary gland disorders, the common causes of xerostomia, Jagran syndrome, and management of xerostomia. I hope this will help you, but you need to be elaborative in the short notes also. Okay, thank you for now, and we'll stay in touch and keep on doing our assignments.